Okay, so today we're going to talk about high resolution CT of the chest, and much of this will be review of material that we've covered before, so we're going to move rather quickly. We will talk about the technique, the anatomy, and mostly about the vocabulary about high resolution CT findings, and then diseases that have a characteristic appearance on high resolution CT that we want you to be able to recognize. So if I ask you this question, slice thickness for high-res CT of the chest should be which of the following? Well, the answer is that this defines high-res CT a slice thickness of less than or equal to 1.5 millimeters. So what is involved in the technique for high-res CT? Well, the collimation should be, the slice thickness should be between 0.625 and 1.5 millimeters. Spacing, now with multi-detector CT, we do it with contiguous slices, and this is also important. The reconstruction algorithm, we use a high spatial frequency or bone algorithm to bring out edge detail. Usually this is done at full inspiration. However, you may do selected expiratory scans if we are looking for air trapping, let's say for underlying disease like bronchiolitis obliterans. Now, this is what a thin section CT looks like. It's standard algorithm, and this is what it looks like after applying a bone algorithm or edge enhancing algorithm. And you can see that the edge enhancing algorithm really brings out the detail much better in this person with emphysematous changes. So this is something that adds to the clarity of high-res CT when we're looking for disease of the lung parenchyma to add on this edge enhancing lung or bone algorithm here. Now, this is not going to help you to look at the soft tissues because this makes the soft tissues a little bit harder to interpret. The soft tissue detail is much smoother when we look at it under standard algorithm. So you will need to look at both sets of images. You'll look at standard algorithm, look at the soft tissues, and then the lung or bone algorithm to look for detail in the lung parenchyma. So here again is an example of somebody with fibrosis, and you can see some traction bronchiectasis here surrounding by this area of ground glass attenuation. But with the edge enhancing algorithm, that traction bronchiectasis looks much clearer, so you get some better images when we're looking for parenchymal lung disease when we apply the edge enhancing algorithm. Now, the necessity for thin sections is demonstrated here. So this is what a 5 millimeter thick section looks like. Because of all the volume averaging, you kind of lose all the detail here. And it's when we go to the thin section, whether it's standard or bone algorithm, that you can really see this area of traction bronchiectasis here, telling you that this is a patient who has fibrotic lung disease. So all of our dedicated chest CT scans are routinely done with thin sections. So in essence, all of our dedicated chest CTs are high resolution CTs. So our chest CTs are done at 1.25 millimeter contiguous sections. This is somebody with widespread cystic lung disease, you can see here. And the advantage of using thin sections, not only for delineation of the lung parenchyma here, but also when you're doing multiplanar reformatting, you get very nice high resolution images regardless of what plane you reconstruct the images in. Now, CT of the chest is usually done supine, but we may do prone imaging for selected cases if we're looking for subtle posterior basal abnormalities, such as in patients who have early idiopathic pulmonary fibrosis or patients with asbestosis. So prone imaging you might do in those types of patients. So in summary, for high-res CT, we do it at full inspiration. We might do selected expiratory scans if we're looking for air trapping, underlying diseases like bronchiolitis obliterans, small airway disease. And you might do expiratory scans at selected levels like the arch, carina, or the lung bases. Now, how can you identify expiratory images? Well, on expiration, the posterior wall of the trachea here bows forward. So if you see that, you can tell that it was an expiratory image. So the normal inspiratory image, the trachea is round. On the expiratory image, the posterior wall of the trachea there bows forward. And here's a nice example where you can actually see the patient is breathing while we're obtaining the CT scan, and you can see that posterior wall of the trachea going back and forth. In expiration, the posterior wall there will bow forward in this patient who has lots of centrilobular emphysema. Now, if we do images at expiration, it's helpful for looking for air trapping. So there might be areas of normal air trapping, like the superior segments of the lower lobes or the anterior middle lobe or lingula, sometimes individual pulmonary lobules within the lower lobe, as demonstrated here, might also demonstrate air trapping. So you have to be careful when you're interpreting air trapping here on some patients. So the expiratory CT can also look like ground glass attenuation. So that's not from disease, that's just because the air is out of the alveolar spaces, increasing the attenuation. So it looks like you have some patchy ground glass attenuation here on expiration, but on inspiration you can see that everything is normal. There is no evidence of infiltrative disease. So in summary, thin sections 0.625 to 1.5 millimeters, usually contiguous slices, and the reconstruction algorithm, we want to look at images that are reconstructed with high spatial frequency algorithm, bone algorithm, or lung algorithm. So again, standard algorithm looks like this. The high-res algorithm looks like this. Now, truthfully, I've never seen anything on the high-res algorithm that I don't already see on the standard algorithm, but it does make for much prettier pictures, especially if you have interstitial lung disease. Now we need to talk a little bit about the anatomy here that we can see on high-res CT. We'll talk about the pulmonary interstitium, bronchi and pulmonary arteries, and the secondary pulmonary lobule. So the pulmonary interstitium is classically divided into the bronchovascular or the central interstitium, and then we have the subpleural or the peripheral interstitium, and then the intralobular interstitium along the alveolar walls is what connects the two. So in this micrograph we can see the bronchi here adjacent to a very small pulmonary artery, so the artery travels alongside the bronchi there, and the diameter is about equal of the bronchi and the pulmonary artery. So bronchi that are less than 2 millimeters in diameter and less than 2 centimeters from the pleural surface are normally not visible on high-res CT because the walls are very thin, less than 0.2 millimeters, and usually not resolvable on high-res CT. So apparent bronchial wall thickening, sometimes on high-res CT, might be due to thickening of the peribronchial interstitium or peribronchial cuffing. Now, the secondary pulmonary lobule, you need to be familiar with this. This is the smallest unit of lung marginated by connective tissue septae. So the average diameter is about 11 to 17 millimeters. It is supplied by a centrilobular bronchiole here, diagrammatically represented, and a centrilobular arteriole. There are interlobular septae in the periphery here, and these contain pulmonary veins, small pulmonary veins, and also contain lymphatics. So these interlobular septae are normally easier to see in the periphery of the lung. So when we look here in the periphery of the lung, we can see the outlines here of the secondary pulmonary lobules in this gross specimen. So these interlobular septae there are easier to see in the periphery of the lung. Normally, except for the periphery of the lung, we usually do not see interlobular septae on high-res CT unless they are thickened for some pathologic reason. And again, the interlobular septae contain small branches of pulmonary veins and also contain lymphatics. So the secondary pulmonary lobule is usually made up of 12 or fewer pulmonary acini. And the acinus is the largest unit in which all of the airways participate in gas exchange. So this is found distal to the terminal bronchiole. It's supplied by a first-order respiratory bronchiole, and acini are usually about 6 to 10 millimeters in diameter, and you can have up to 12 acini within one secondary pulmonary lobule. So when we look diagrammatically at the anatomy here, we have the interlobular septae, and within the or along the interlobular septae you will have pulmonary veins and lymphatics. Within the center of the secondary pulmonary lobule, we have our centrilobular or lobular core structures, which consist of the centrilobular artery and the centrilobular bronchiole. And then we have the lobular parenchyma also here scattered around here in the secondary pulmonary lobule. Now, the intralobular artery This will give us a linear or dot-like opacity in the center of the lobule on high-res CT. As you said, the intralobular bronchiole is usually not resolved unless there's something abnormal. And so comparing the anatomy to what we see on high-res CT, diagrammatically, this represents what we will see on high-res CT. So the airways, 3 millimeters in diameter, or less than 3 centimeters from the pleura, are usually not visible on high-res CT. We can see the centrilobular artery on high-res CT. We will not see the normal centrilobular bronchiole. And these interlobular septae, these will be visible usually within the periphery of the lung. So when we look at a high-res CT, what will we see here? Well, when we look here in the center of the secondary pulmonary lobule, we can see the centrilobular artery. Normally, we do not see the centrilobular bronchiole. We might see interlobular septae here in the periphery. This one is next to the major fissure here. And along the interlobular septae, we might see these vascular structures, and these represent pulmonary veins. So that is the anatomy that we can see on high-res CT. Here's another dot here in the center of a secondary pulmonary lobule that represents a centrilobular artery. So the interlobular septae, again, more prominent towards the periphery, closer to the pleural surfaces, and we can see vascular structures running in the periphery, which represent the small veins that are running alongside the interlobular septae. Another example here where we can see a centrilobular artery here within the center of the secondary pulmonary lobule, and then here we see some interlobular septae. Again, normal to see these towards the periphery of the lung. Here's a patient with emphysema, and this brings out nicely the central dot-like opacity representing the centrilobular artery here. This patient also has some CHF, which brings out this interlobular septal thickening, nicely marginating these secondary pulmonary lobules. So you can see the shapes of these secondary pulmonary lobules in this patient. Now in this micrograph, it shows us the lobular parenchyma, the components of the lobular parenchyma here. We have the functioning lung parenchyma of the alveoli and the associated pulmonary capillary bed, and it's all this interstitial stuff here. So that represents the alveoli. And we have you can see the bronchi here, and we could see the artery here. In the intralobular interstitium, there's this fine network, this fine reticular network that you can see here within the secondary pulmonary lobule. Some of that is composed by connective tissue there that is in the intralobular interstitium. So when we have crazy paving, not only do we have ground glass opacity with interlobular septal thickening, but you can also see inside of the secondary pulmonary lobule, you can see this reticularity inside the secondary pulmonary lobule, and that represents thickening of the intralobular interstitium. So crazy paving is when we have ground glass with both interlobular and intralobular septal thickening. Typically, alveolar proteinosis is the classic disease, but as we've spoken about before, it's really a nonspecific finding, and just about anything that can give you consolidations might give you crazy paving. But the key is this crazy paving appearance. Not only do you get interlobular septal thickening, but when you look inside the secondary pulmonary lobule, you can also see reticularity, which is intralobular septal thickening. So that's what we call crazy paving. Now, typically high-resolution CT findings of lung disease are divided into these four categories: linear and reticulonodular opacities, nodules and nodular opacities, increased lung opacity, and abnormalities associated with decreased lung opacity. So linear and reticulonodular opacities, usually this is thickening of the interstitial fiber network. It could be caused by fluid, fibrous tissue, infiltration by cells or other material. So we're talking about causes of interlobular septal thickening. Now, when we have these linear reticular nodular opacities, these can be These can give you interlobular septal thickening. These can give you intralobular interstitial thickening. These might give you peribronchovascular interstitial thickening, honeycombing, parenchymal bands, subpleural lines. So we need to be familiar with what these terms mean in terms of vocabulary. So interlobular septal thickening should be very familiar to you. So this is the thickening of the interlobular septae outlining the secondary pulmonary lobule, and we can have smooth thickening, which can be caused by most commonly pulmonary edema, but occasionally lymphangitic carcinomatosis, a rare disease like alveolar proteinosis might do that. Nodular thickening, remember pulmonary edema does not give you nodular thickening of interlobular septae. We can see that with lymphangitic carcinomatosis, sarcoid, occasionally silicosis, and co-workers pneumoconiosis. And irregular thickening usually is a manifestation of fibrosis. So we can see that with sarcoid or UIP. So we've seen this case already of somebody with centrilobular emphysema and CHF. You can see this very smooth interlobular septal thickening as a result of interstitial edema from CHF. Sometimes lymphangitic carcinomatosis can also give you smooth thickening of interlobular septae, as in this example. But typically, though, lymphangitic carcinomatosis is associated with nodular thickening of interlobular septae, as in this example. So here you have interlobular septal thickening outlining the secondary pulmonary lobule, somewhat nodular thickening. And when we see that with marked thickening of interlobular septae, you want to think about lymphangitic carcinomatosis. Now, we can also have intralobular septal thickening. So we talked about that with alveolar proteinosis, but there are other diseases that might also do that. This is a case of somebody with idiopathic pulmonary fibrosis, and you can see when we look inside the secondary pulmonary lobules, there is some reticularity here from intralobular interstitial thickening. So the diseases that give you fibrosis might also give you intralobular septal thickening. So here's a nice example of somebody with idiopathic pulmonary fibrosis with these reticular abnormalities representing also intralobular septal thickening, in addition to some interlobular septal thickening. Chronic hypersensitivity pneumonitis, another fibrotic disease that might also give you intralobular septal thickening. Again, the point here is not to memorize a list of these diseases, but just showing you examples of these appearances on high-res CT and what these appearances mean. So here you can see architectural distortion with traction bronchiectasis, reticular abnormalities, and the architectural distortion and traction bronchiectasis tells us that this is a fibrotic disease. We can see that there's marked air trapping here, which should make you think of hypersensitivity pneumonitis, but these fine lines here represent some intralobular interstitial thickening in this example. Alveolar proteinosis we've already covered as a cause of both interlobular and intralobular septal thickening with ground glass opacity, and we call that crazy paving when we see that particular appearance. Now you can also have peribronchovascular interstitial thickening, so interstitial thickening around the bronchi. So we would call that peribronchial cuffing if we see that. And again, that might be smooth or it might be nodular. So smooth thickening we can see with lymphangitic cancer, interstitial pulmonary edema, nodular thickening, again, lymphangitic cancer, sarcoid, and irregular thickening, as we've talked about. Lung fibrosis might do that. So here's an example of sarcoid giving you somewhat nodular peribronchovascular thickening. You see these nodules here, nodular kind of opacities and some nodular thickening around these bronchial structures. And lymphangitic carcinomatosis that might give you smooth or nodular, in this case it's somewhat smooth, thickening here in the peribronchovascular region. Here it's around the bronchi in this particular example. So honeycombing is when we have extensive fibrosis and you see these stacked cysts in the periphery. And of course, you could think of idiopathic pulmonary fibrosis here, but any disease that gives you marked fibrosis might give you honeycombing. And so honeycombing represents this fibrosis and really traction bronchiectasis here affecting the airways within the secondary pulmonary lobule. And here you can see the stacked cystic appearance with the thickened walls, the typical appearance of honeycombing. So honeycombing, small cystic spaces with thick walls. The cysts usually shear walls, it predominates in the periphery of the lung, and usually it's in several contiguous layers. So you want to be able to recognize honeycombing on high-res CT. So honeycombing indicates lung fibrosis. Usually it's associated with other findings of fibrosis like intralobular interstitial thickening, traction bronchiectasis, irregular subpleural interstitial thickening, and of course common causes that cause fibrosis like idiopathic pulmonary fibrosis, but there are other diseases like asbestosis, chronic hypersensitivity, pneumonitis, sarcoid. All of these might give you honeycombing. An example of honeycombing with peripheral subpleural honeycombing here in somebody with idiopathic pulmonary fibrosis. And here's an example of somebody with hypersensitivity pneumonitis. You can see the marked air trapping here, and then this also giving us honeycombing here on this prone CT scan in this particular patient. Some more vocabulary terms: parenchymal bands. These are reticular opacities that are usually perpendicular to the pleural surfaces, as in this example. So this might represent Peribronchovascular fibrosis, could represent scarring, could represent atelectasis associated with fibrosis. So parenchymal bands usually associated with diseases that cause pulmonary fibrosis. We can see it with asbestosis, and we might see it with some of these other diseases also. So it's not really specific for asbestosis, but it is commonly associated with asbestosis. Now, subpleural lines, again, another vocabulary term. These are these lines that run parallel in the subpleural region to the pleural surfaces, these curvilinear opacities. And again, this is an indicator of atelectasis, fibrosis, or inflammation. Again, this is associated with diseases that cause fibrosis, commonly asbestosis, but it can be associated with other diseases that might also cause fibrosis. So you want to be able to differentiate this from dependent atelectasis, and this is where prone imaging can be helpful because this might be an early finding of asbestosis. So let's talk about now the next category of abnormalities: nodules and nodular opacities. So when we look at nodules, we want to think about the appearance. Are they well-defined or ill-defined? Are they small, less than 1 centimeter? Are they large, greater than 1 centimeter? What's the attenuation? Is it soft tissue or ground glass attenuation? The most important thing when we're dealing with a micronodular pattern is going to be the distribution. Is it a random, perilymphatic, or centrilobular distribution? So when we have airspace nodules, usually from inflammatory diseases, these are usually ill-defined, tend to be centrilobular or peribronchiolar. So this usually represents lobular pneumonia or bronchopneumonia. And now when we're talking about micronodules, the important thing we want to decide is the distribution. Is it a random distribution, perilymphatic distribution, or centrilobular distribution? So as we've covered before, the best way to approach the distribution is to first look at the pleural surfaces. If the nodules are not touching the pleural surfaces, then you're dealing with a centrilobular distribution of nodules. Centrilobular distribution usually related to airway disease. If the nodules are touching the pleural surfaces, then we might be dealing with a random or perilymphatic distribution. The next thing you want to look at is the fissures and the interlobular septae. If there's a preponderance of nodules along the peribronchovascular regions, along the fissures, along interlobular septae, then we have a perilymphatic distribution of nodules, and the diseases that you might think about there are sarcoid and lymphangitic carcinomatosis. And if you don't have that, then you might be dealing with a random distribution of nodules. And here we think of hematogenous dissemination as the underlying mechanism of giving you a random distribution of nodules. So the diseases in that category you would consider are miliary infection, like miliary tuberculosis, or metastatic disease, hematogenous spread of metastatic disease. So random distribution of nodules, usually from hematogenous dissemination. Diseases we think about: miliary TB, miliary fungal infection, or hematogenous metastases. This is an example of miliary tuberculosis, giving you a random distribution of nodules. Another example of somebody with random nodules, and here it was hematogenous mets. Notice here that there's more of a difference in the size of the nodules, which might make you more suspicious for metastatic disease. Perilymphatic distribution of nodules. So here we look for a distribution of nodules along the fissures, along the subpleural regions, along the Perironchovascular regions. And the diseases we think about when we have a perilymphatic distribution of nodules, we think sarcoid, lymphangitic carcinomatosis, and silicosis occasionally, and co-workers pneumoconiosis might also give you a perilymphatic distribution of nodules. So here's an example of sarcoid here, giving you nodules along interlobular septae here, and here along the fissure. Here, nice outlining of the secondary pulmonary lobule as these nodules are along the interlobular septae, so that is a perilymphatic distribution of nodules. Here's an example of silicosis and co-workers pneumoconiosis, giving you a somewhat also perilymphatic distribution of nodules. So with silicosis and co-workers pneumoconiosis, nodules can be centrilobular and perilymphatic. Remember the pathophysiology here, especially with silicosis, is that the macrophages will take up the silicosis, and then they will take it to the lymph nodes, and that's why we get changes within the lymph nodes, the eggshell calcifications from silicosis. And so these macrophages, they travel through the lymphatics, hence you might get nodules in a perilymphatic distribution. Lymphangitic carcinomatosis, this is another disease that can also give you a perilymphatic distribution of nodules, and this tends to be associated also with interlobular septal thickening. Now, a centrilobular distribution of nodules, here we think of airway disease if we have a centrilobular distribution of nodules. So you might have tree and bud, or you might have nodules not associated with tree and bud. If we have tree and bud nodules, we think of infectious bronchiolitis, tuberculosis, atypical mycobacterial infection, any airway disease, cystic fibrosis, bronchopneumonia. We've talked about Asian panbronchiolitis before. So any infection of the airways might result in tree and bud nodules. Now we can also have centrilobular nodules without tree and bud. And again, we've said that we might sometimes see that with sarcoid, silicosis, and occasionally with lymphangitic carcinomatosis. So centrilobular nodules without tree and bud, what are the most common diseases that we should think about here? Well, infection, you might have infection without tree and bud, and we've listed the infections here. If it's ground glass opacity, it might be ground glass opacity centrilobular nodules, might be hypersensitivity pneumonitis. If the patient is a smoker, it might be respiratory bronchiolitis. Langerhans cell histiocytosis, this can also give you centrilobular nodules without tree and bud, and early stages of asbestosis might also do that. So this is somebody with bronchopneumonia who has these centrilobular nodules here without tree and bud opacities. This is somebody with LCH who has centrilobular nodules. You can see some of these are cavitary. This is somebody with some fluffy kind of ground glass attenuation centrilobular nodules. This is associated here. In this case, this is from hypersensitivity pneumonitis. Here's a patient who's a smoker who has centrilobular ground glass attenuation, and this is from respiratory bronchiolitis. So here's the algorithmic approach. If we're dealing with micronodules, we want to decide first, are they touching the pleural surfaces? If they're not, then we're dealing with centrilobular nodules. Are there tree and bud opacities? If there are, then we're going to think of TB, atypical mycobacterial infection, diffuse panbronchiolitis. If there is no tree and bud, then again, you might still be dealing with infection, but there are other diseases of airways that can give you inflammation around the centrilobular bronchiole, like hypersensitivity pneumonitis, respiratory bronchiolitis, occasionally BOOP, e.g. some pneumoconioses, as we've said, like silicosis, co-workers pneumoconiosis, and even sometimes asbestosis in the very early stages at the lung bases. Now, if they are touching the pleural, surfaces, we need to decide, are they perilymphatic or random? If they are perilymphatic, then sarcoid and lymphangitic carcinomatosis are the first things that come to mind, although occasionally silicosis and co-workers pneumoconiosis can do it. And if it's a random distribution of nodules, we think of hematogenous dissemination like metastatic disease and miliary disease, miliary infection. So an example of random nodules here from miliary metastatic disease, centrilobular ground glass attenuation nodules in this patient with hypersensitivity pneumonitis. And here this patient has centrilobular nodules with tree and bud opacities. This is somebody with mycoplasma pneumonia, infectious bronchiolitis. Now large nodules Nodules greater than 1 centimeter are considered large. If the lesion is greater than 3 centimeters, it's considered a mass. We no longer call it a nodule. So large nodules and masses might result from conglomeration of small nodules. So sarcoid can do that in the upper lobes. So we can see that with progressive massive fibrosis. We can also see progressive massive fibrosis with silicosis and co-workers pneumoconiosis. So with sarcoid, you might see these larger opacities here within the upper lobes from coalescence of the small nodules as a result of the fibrosis, again representing progressive massive fibrosis, and we might see similar findings also with silicosis, and sometimes this can pull on the adjacent lung and give you these peripheral regions of emphysema from the fibrotic change. So let's move on now to diseases that give you increased lung opacity. So if we're talking about increased lung opacity, we might be talking about ground glass attenuation, or we might be talking about consolidation. So the definition of ground glass attenuation, this is a purely descriptive term. This is a hazy parenchymal opacity that does not obscure the underlying architecture. So you have hazy opacity here, but you can still see the blood vessels here through the hazy opacity. So we call that ground glass. So we can see it diffusely with viral pneumonias, as I'm sure you're all familiar with now in this era of COVID. So this diffuse patchy ground glass opacity here in this example, and you can see the underlying lung architecture is not obscured. You can see the blood vessels clearly through these ground glass opacities. Now, ground glass in and of itself is a purely non-specific finding. So we can see it from fluid within the alveolar spaces. You can see it from thickening of interlobular septae from fibrosis. You can even see it on expiration. Expiration can also give you ground glass opacity. So ground glass in and of itself is not really a specific finding. So here's an example of a normal patient inspiration, expiration. You see some ground glass here on the expiratory scan. So you might call this pseudo ground glass opacity. Here's a patient who is supine, and you can see this dependent atelectasis here. When you turn the patient prone, it goes away and moves to the other side. So you might call that pseudo ground glass opacity. The significance of ground glass opacity is that when it indicates disease, it might indicate active and a treatable process. So with interstitial lung disease like pulmonary fibrosis, if we see ground glass opacity away from areas of pulmonary fibrosis, then it might indicate an active inflammatory process. So you would want to direct lung biopsy towards those areas. On the other hand, when we see ground glass opacity here surrounding regions of traction bronchiectasis, then usually the ground glass here represents fibrosis that is below the resolution of CT. So you would want to avoid biopsying these areas, since your biopsy would just probably show fibrosis that might be difficult for the pathologist to interpret. Other things that can give you ground glass, we've talked about discriminative interstitial pneumonitis, peripheral ground glass opacity associated with that. Again, this is in smokers, and that of course can respond if the patient stops smoking or is treated with steroids. The term consolidation means you have an opacity that you cannot see through. So the consolidation obscures the underlying lung architecture. So we've talked about diseases that give you alveolar processes or consolidations. You can have pulmonary edema, blood, pus, cells, protein. All of these can fill the alveolar spaces and can obscure the underlying lung architecture. So many causes of ground glass opacities: pulmonary edema, infection, idiopathic interstitial pneumonias that we've talked about before, hypersensitivity, pneumonitis, alveolar proteinosis, many causes. So the list goes on forever. So ground glass in and of itself is not really a specific finding. This is ground glass here in a patient with pulmonary edema as emphysema. Notice these areas of emphysema. You don't see the consolidations, and you see the ground glass opacity here in the more normal areas of the lung parenchyma. So with infections like pneumocystis pneumonia, common to see ground glass opacity associated with that. Here's a pneumatocele in this patient with pneumocystis pneumonia. With UIP, or idiopathic pulmonary fibrosis, ground glass opacity could be peripheral, posterior basal, although it's the findings of fibrosis like the honeycombing that will usually predominate in these cases, and the traction bronchiectasis. NSIP, we will see ground glass opacity associated with traction bronchiectasis, and subpleural sparing might be a finding that is also associated with NSIP. Usually no honeycombing with NSIP. So let's move on now to abnormalities associated with decreased lung opacity. So again, some vocabulary terms you need to be familiar with: honeycombing, emphysema, bullae, pneumatoceles, cysts, bronchiectasis, cavitary nodules, mosaic, perfusion, and air trapping from airway disease. So if I show you these images, what is illustrated here? What is illustrated here? Of course, this is an example of centrilobular emphysema. You have these centrilobular areas of lucency with imperceptible walls. This is panlobular emphysema. This is more diffuse and extensive. This predominates at the lung bases. This is associated with alpha-1 antitrypsin deficiency, whereas this predominates in the upper lungs, and this is associated with smoking. Again, we've seen numerous examples of this. This is honeycombing, and you want to be able to recognize that. These stacked cysts, more so in the periphery of the lung. Here's an area of traction bronchiectasis, helping to tell you that this is a fibrotic process. So you want to be able to recognize honeycombing. The different forms of bronchiectasis according to the Reed classification: cylindrical, varicose, cystic. Again, we have covered this, and this also can manifest as these areas of abnormal lucency within the lung. You can usually tell these are bronchi because you can connect them to the bronchi, and rather than being round, they're somewhat tubular. So holes in the lung on CT. What can give you holes in the lung on CT? We can see that with cavities, honeycombing, centrilobular emphysema, blebs, pneumatoceles, lung cysts like with Lamb or Langerhans cell histiocytosis, and with bronchiectasis. Cavitary nodules, we've talked about the differential of cavitary nodules. This is somewhat metastatic squamous cell cancer. So of course we can see it with infections, cavitary metastases. Some rarer lesions like rheumatoid lung disease can give you cavitary lesions in the lung. LCH can give you cavitary lesions, and of course Wegener's granulomatosis can also do that. Honeycombing, we've described honeycombing, so I'm sure you're very familiar by now with the appearance of honeycombing. So with honeycombing, the cysts share walls, unlike the cysts with EG and Lamb. Emphysema, I'm sure we're all now familiar with emphysema, with centrilobular, panlobular, paraseptal, and cicatricial. Now, another clue that you might be dealing with centrilobular emphysema is the preserved centrilobular artery. Notice that dot sometimes in the center here. That is a preserved centrilobular artery. You will not see that with cystic lung disease. You will see that with centrilobular emphysema. So, and of course, centrilobular emphysema is associated with smoking. Panlobular emphysema associated with alpha-1 antitrypsin deficiency, tends to be worse at the lung bases. Paraseptal emphysema, this occurs in the periphery of the lungs, along the pleural surfaces, and also along the mediastinum. This is associated with spontaneous pneumothorax in young people. You want to differentiate paraseptal emphysema from honeycombing. With honeycombing, the cysts are smaller. You have layers of cysts. This tends to predominate at the lung bases, and you have other evidence of fibrosis. Whereas with paraseptal emphysema, it's usually a single layer of cysts, and you have other findings of emphysema, but not fibrosis. Now, we can also have cicatricial emphysema in this patient with progressive massive fibrosis, as this pulls on the adjacent lung and gives you these cystic air spaces from emphysema as a result of scarring. And so, what's the difference between bullae and blebs? Well, bullae is a sharply demarcated area of emphysema, at least 1 centimeter in diameter, has thin walls, very commonly found in the lung apices, but is usually associated with extensive centrilobular or paraseptal emphysema. A bleb is a gas-containing space in the visceral pleura. It's a thin-walled lucency, usually at the lung apex, and I will tell you, you cannot always differentiate a bleb from a bulla. So these are obvious bulla in this patient with emphysema, so no problem with that. But sometimes when you see these very small lesions like that at the lung apices right along the visceral pleural margins, are these areas of emphysema or are these blebs? Remember, these can also cause spontaneous pneumothorax if they are blebs. So it's not easy to tell the difference with CT. So cases like this, it could be either. Might be an area of emphysema or might be a bleb. Pneumatoceles are thin-walled these thin-walled gas-containing lesions here, usually associated with pneumonia, usually transient, usually gets better. Commonly seen with pneumocystis pneumonia when we have ground glass opacity like this in areas of pneumatoceles, although we can also see this with staphylococcal pneumonia. And then lung cysts, we've talked about cystic lung diseases, LAM, Langerhans cell histiocytosis. So we've talked about these diseases that can give you lung cysts. Here's somebody with cystic lung disease, but also has this strange lesion in the kidney. So that, of course, is an angiomyolipoma and or an AML. So these, in this case, then we would be thinking about tuberous sclerosis. And here's a patient who has cystic lesions here in the lung with these solid renal masses. So this patient has renal cancer associated with these with this cystic lung disease. So this is a patient with Birt-Hogg-Dubé syndrome. So Birt-Hogg-Dubé, autosomal dominant dermatological disorder. It's associated with cutaneous hair follicles or fibrofolliculomas, pulmonary cysts, and renal cancer. Bronchiectasis, we've talked about the different forms of bronchiectasis, another cause of lucent lesions within the lung. Cylindrical, varicose, cystic, of course we are now very familiar with this. And traction bronchiectasis from scarring, another form of bronchiectasis. This patient with tuberculosis has some chronic right upper lobe atelectasis, and you can see these areas of traction bronchiectasis within the area of right upper lobe scarring. Another thing that can give you lucency within the lung, mosaic perfusion. This is when we have areas of decreased attenuation, but we also have decrease in the size of the blood vessels here within these areas. So that is mosaic perfusion. In this case, it's caused by airway disease, bronchiolitis obliterans. Remember the two major causes of mosaic perfusion, most commonly airway disease, small airway disease, and less common cause is vascular disease. So mosaic perfusion, with bronchiolitis obliterans, it can give you air trapping, and that air trapping will be accentuated on expiration. But we can also see this sometimes in a much less commonly, though, associated with vascular disease like chronic pulmonary embolism. So with mosaic perfusion from airway disease, the areas of low attenuation usually conform to the pulmonary lobules. You might see dilated or thick-walled bronchi, giving you a hint that the patient has airway disease, and air trapping will be accentuated on the expiratory scan. So think of the small airway diseases that can do this, COPD, cystic fibrosis, but if it's pure air trapping is the only finding, constrictive bronchiolitis or bronchiolitis obliterans. Then on expiratory imaging, you will see the air trapping much better. So if we're looking for bronchiolitis obliterans, we want to make sure to do expiratory imaging. Now again, sometimes you might see mosaic perfusion from vascular disease. So here, this areas of mosaic perfusion, usually larger, usually not breaking down into pulmonary lobules like we see with airway disease. And here the most common cause is chronic pulmonary embolism, chronic pulmonary thromboembolic disease. The clue will be the large pulmonary vessels because the patient has signs of pulmonary artery hypertension. So it's another nice example, mosaic perfusion here, and you can see this eccentric thrombi from chronic pulmonary thromboembolism there along the right pulmonary artery. Now the Hrct sign, which gives you these areas of lower attenuation, ground glass attenuation, regions of air trapping. So it's a mixture where we see these lobules of air trapping, lobules that might look normal, lobules with ground glass opacity. So what disease is associated with Hrct sign? So this is a mixed disease where we have both an infiltrative component and an air trapping component, and most commonly this is seen with hypersensitivity pneumonitis. So we have this patchy geographic pattern of mixed density resulting from a combination of ground glass opacity or consolidation, normal lung, decreased attenuation from mosaic perfusion, and air trapping. So this indicates a mixed infiltrative and obstructive process, usually related to bronchiolitis, and the air trapping will be accentuated on expiratory scans. So it was thought that this appearance looked like head cheese, which is a sausage that is popular in the Midwest, and so hence the term the Hrct sign when we have these lobules of differing attenuation there on a CT scan. So the common diseases, the most common disease that gives you the head cheese sign is hypersensitivity pneumonitis, but other diseases that can be associated with it, sarcoid, atypical pneumonias, and DIP, RBILD might also be associated with the head cheese sign. Now, for the next part of this, let's go through diseases, and all of this should be familiar to you at this point. Diseases that might have a diagnostic appearance on high-res CT. So if you see a disease like this with these findings of honeycombing here in the periphery of the lungs, more predominant at the lung bases, so we should think about, here's diagrammatically, you can see the fibrosis and the honeycombing. Idiopathic pulmonary fibrosis in this case. This is a UIP pattern in this particular case, and we have covered this in the findings associated with idiopathic pulmonary fibrosis. On the other hand, if we see changes that resemble pulmonary fibrosis here in this case, but look very carefully on the second image and you might be able to come up with the diagnosis. So I hope that you've noticed this little bit of pleural thickening and pleural calcification. So if we have pleural calcification associated with findings of fibrosis, you want to think of asbestosis. So if we have changes indicating asbestos exposure here along the pleural surfaces, with fibrotic changes, we want to think of asbestosis. So we can have findings of fibrosis associated with asbestosis. We've talked about parenchymal bands, subpleural lines, these subpleural dot-like opacities, this peribronchovascular fibrosis at the lung bases can be the earliest finding of asbestosis. And of course, if we see parietal pleural thickening or pleural plaques, that tells us that the patient has had asbestos exposure. So if we see parenchymal abnormalities associated with that, then we want to think about asbestosis. The earliest parenchymal changes associated with asbestosis will be posterior and basal. So you want to scan these patients prone, especially early on in disease. These posterior subpleural dot-like opacities, subpleural lines here, these are the earliest findings of asbestosis. Here's a more advanced case showing you findings of fibrosis on that particular CT scan. Now, what about a case like this? Well, notice we have marked interlobular septal thickening, somewhat thick and nodular here. You might wonder if this is a mass in this case. There's bilateral disease, so that should give you a clue. So here you're going to be thinking about lymphangitic carcinomatosis. So this can give you smooth or nodular interlobular septal thickening, but especially nodular interlobular septal thickening. There will be no associated fibrosis or signs of architectural distortion. With certain tumors like breast cancer and lung cancer, it might be asymmetric and predominantly unilateral. You might also have adenopathy or pleural effusion associated with that. So here's a case of breast cancer with predominantly unilateral changes here of interlobular septal thickening and nodular opacities from lymphangitic carcinomatosis. If we look carefully, there are also some changes on the other side, but there is a marked asymmetry here in this patient with breast cancer. Now, what about this case? This patient has a diffuse micronodular pattern, and again, we want to look at the distribution of the nodules, and we notice here that the nodules are studding the pleural surfaces here, the fissures. So we're going to think about a perilymphatic distribution in this case. You can also see nodules along the vessels. This patient also has enlarged hilar opacity, so bilateral hilar adenopathy with perilymphatic nodules. This is a patient with sarcoidosis. So perilymphatic distribution of nodules, we can also see that with sarcoid. Sarcoid tends to give you more nodules when we have these perilymphatic nodules, as opposed to lymphangitic carcinomatosis, which gives you more interlobular septal thickening. So if the disease is predominantly perilymphatic and nodular, think sarcoid, especially if it's more in an upper lung distribution. And if the disease is predominantly nodular interlobular septal thickening, especially in a lower lung distribution, you think lymphangitic carcinomatosis. So sarcoid will give you this perilymphatic distribution of nodules, as in this case that we have illustrated here. Other cases of sarcoid might give you fibrosis, especially kind of in an upper lung distribution, architectural distortion, traction bronchiectasis, and you might also get progressive massive fibrosis with sarcoid also. So here's a case of progressive massive fibrosis here with eggshell calcifications. So here we want to think silicosis. So eggshell calcifications are very closely associated with silicosis. So silicosis and co-workers pneumoconiosis, this can give you centrilobular or subpleural nodules. Nodules might be dense, especially with silicosis, tends to have an upper lung distribution of disease. This I hope we can all recognize now. These are tree and bud opacities, and when we see that, we will think of infectious bronchiolitis when we see tree and bud opacities. So infectious bronchiolitis gives you tree and bud, and we're all familiar with the diseases that might give you infectious bronchiolitis. Here we have centrilobular nodules. Notice they are not touching the pleural surfaces. These are mostly ground glass attenuation. So what do we think about here? Well, here we think about hypersensitivity pneumonitis. So hypersensitivity pneumonitis gives you centrilobular ground glass opacities, and it can also give you air trapping on expiratory views. Now, we also mentioned if the patient is a smoker, in that case you might think respiratory bronchiolitis. So subacute hypersensitivity pneumonitis, centrilobular ground glass opacities. Now, what about this case? Cystic lung disease, very bizarre shaped cyst, tends to be worse in the upper lung distribution. So this is the typical appearance of Langerhans histiocytosis when we see that. Cysts can be bizarre in terms of shape, tends to have an upper lung distribution. You might also have nodules associated with this with Langerhans histiocytosis. Another example here of these bizarre shaped cysts here in this patient with LCH. Here we have diffuse cystic lung disease here, and the cysts are somewhat more uniform in size. So this is the appearance of lymphangioliomyomatosis. So this is seen, of course, in females of childbearing age. More diffuse lung disease here. Usually we do not see nodules associated with this. You may have chylous pleural effusions. You may have lymphadenopathy. So to differentiate LCH from LAM, LAM is only females, involves the lung uniformly. The cysts are more uniform in shape, no nodules, and you might have chylous pleural effusions. So I hope all of you can recognize this at this point. We have these centrilobular lucencies here. Here there is a preserved centrilobular artery. So this is the appearance of centrilobular emphysema. So we have centrilobular lucencies, imperceptible walls, and preserved centrilobular artery in some of these areas of lucency. So we've talked about the different forms of emphysema, centrilobular and panlobular. Centrilobular associated with smoking, worse in the upper lungs. Panlobular associated with alpha-1 antitrypsin deficiency, worse in the lower lungs. And then we've also talked about emphysema that can be associated with scarring. So we can have cicatricial emphysema, and we've also talked about paraseptal emphysema. This patient also happens to have a lung cancer here associated with their paraseptal emphysema. We've talked about bronchiectasis, cylindrical, varicose, cystic. So of course you're familiar now with this, the different appearances of bronchiectasis here and the Reed classification of bronchiectasis. Here we have inspiratory and expiratory imaging, and we see that the predominant finding is air trapping here and mosaic perfusion on the expiratory images. So we want to think of small airway disease, especially bronchiolitis obliterans or constrictive bronchiolitis when we have a finding like that. So with bronchiolitis obliterans, we will have mosaic perfusion, patchy areas, decreased lung opacity. The pulmonary vessels will be attenuated there in those areas of decreased lung opacity, and the air trapping will be accentuated on expiratory CT. You might have some mild bronchiectasis also. So on expiratory CT, the air trapping is accentuated, and you might have some peribronchial thickening and mild bronchiectasis when we are dealing with a case of bronchiolitis obliterans. So in summary, for high-res CT, the most important thing, of course, will always be the clinical information. So do your best to get hold of that before you actually start to interpret the CT scan. We've talked about the vocabulary and try to decide what the predominant abnormalities are on CT, whether they're reticular, nodular, ground glass opacity, cystic, mosaic perfusion, or air trapping. What's the distribution of the abnormalities? If we have fibrosis, is it peripheral, peribronchovascular, basilar distribution, or upper? The nodules, what's the distribution? Are they random, perilymphatic, centrilobular? Do you see tree and bud? Do we have ground glass attenuation or consolidations? What is the distribution? Is it diffuse, peripheral, peribronchovascular? And do we have cystic lung disease? Again, the distribution can be helpful. Is it peripheral, diffuse, or upper lung in distribution? And then putting all of that information together, you can then formulate a differential diagnosis. All right, so thank you for your attention, and we will see you next time.